Give everyone a minute to join. Getting to a reasonable quorum of folks, so I think here at 9:32 we'll kick it off.
Great. Brad, can I give just really brief opening remarks? Okay, great. I'll be super brief. Good morning. Happy day 2 of session for those of you who are involved in that. Today is a really important meeting. I want to build on the momentum that we had from our in-person meeting in January, and we'll walk through the specific goals and things like that. But at a high level, today's where the rubber really meets the road, where we transition from thinking about the priorities and the measurement to the money, and the incentives and the investments that we want to make. We left the conversation last month's with a number of open items. We want to close those, and then we want to try to really make some progress towards recommendations on the money. So I am looking forward to today, and Brad or Olivia, I will hand it back to you to talk about the recap and the goals.
Great, thank you, Guy. Definitely looking forward to continuing the conversation. And so just quick reminder, at our last in-person hybrid meeting on the 18th, we just reviewed and discussed our project to date. We grounded our discussion in an overview of payment models and some examples from states and federal programs, and discussed the base payment options and collateral, and collected some directional feedback from all of you, which there's some additional information in the appendix for today's content that's helpful for review for folks. The next slide, just to say we have heard some feedback from you, and we wanted to incorporate that into some of the materials, so we're going to review that briefly today. And one of them was the importance of behavioral health within the opportunities and care to line priorities. So not just saying it, I think the importance of incorporating it into the written material, which we've tried to do, and you'll see if you haven't had a chance on the next slide, we'll get there in a second. And then the other one is the importance of health-related social needs and our approach to both screening referral as well as community supports. And so we're planning on revisiting that at the March meeting when we review our equity strategy as well. So that is upcoming. On the next slide, you'll see the revision in red, number 5. These are the opportunities ahead we've been discussing. I want to note just say improve chronic condition and behavioral health management with a focus on reducing unnecessary inpatient and ED utilization. And on the next slide, you'll see we also incorporated under the care delivery priority. So under the first one, you'll see it's also in red, chronic condition, behavioral health, and target care management, and updated in the definition of success, calling out practices engaged to support patients in healthy living and in management of chronic conditions and behavioral health. So trying to make sure that we updated that language so that in review for external stakeholders who may not have a chance to listen, they know that it's incorporated. So I do want to take a quick pause, check that this kind of was one of the asks, to make sure that see if there's any further feedback on this. So pausing now. All right.
Great, thank you.
Great. So I think we can move to the next one. Next slide. So our goals for today, as Guy kind of said, is really continue that payment model discussion and really focusing on performance-based payment options. that falls under also named incremental payments. So again, layering on top of the base payment conversation we had last time. And then we're also going to check in on next steps and take stock of where we are and where we're headed. Next slide. So again, reminder that you'll see we've talked about care delivery, performance measurement. We're talking about payment model, and that the kind of key question is, how is primary care paid and incentivized for doing things that improve member health and well-being? So again, today, conversation 2. Next slide. And here's kind of our hope at the end of the discussion, to have directional feedback on topic 2. How should DSS use financial incentives or incremental payments to drive performance and ensure measures and requirements are met? Again, that's today's conversation. The next one tees it up a little bit more and kind of the purpose. So again, this is directional. We're not looking for a final answer or one size fits all. We know that's not what we're going to get today. And I think there's already been a lot of discussion about the variation in practice size, abilities, et cetera. And so we'll be talking about this in a way that enables broad participation in a program. And those strategies to do that might include having tracks or tiers. We discussed that last time. We'll come back again today. Developing a glide path for those practices who want to get to a certain level as part of a participation in the program. And then providing technical assistance providers, as well as thinking about investing in data infrastructure and data sharing or other centralized investments. So all of these are potentially strategies to help with this variability and variation amongst practice. Next slide. So again, this is really the question that we're talking about, is how should we use financial incentives or incremental payments to drive performance and ensure measurement requirements are met. We'll talk about the strengths and limitations of performance-based payment, examples, and then starting point of kind of how we initially assessed it. And then we'll discuss and collect feedback from all of you. Next slide. So these are the strengths and limitations, and I'll also provide just a brief commentary about the different models and what they might look like, just as a reminder. So talking about shared savings and shared risk, that's on the left here. Orienting you again, on the right is pay for performance, and on the y-axis you'll see strengths, limitations, and those on the side. And so shared savings, shared risk, it provides, what is that? It provides a potential shared generated savings when providers essentially for a group of our population spend less than a target amount. So an example of that might be, I am a primary care provider. I have a patient population. The target price, the expected spend at the end of a period of time, let's just say a year, is $1 million. I focus on reducing ED utilization, unnecessary inpatient hospitalizations. At the end of the year, the total spend is $900,000 instead of $1 million. There's a shared savings arrangement. Well, in this case, we'll just say it's a 50-50. So 50 between the payer, 50 between the provider. In this case, again, the provider. So there's a $100,000 gap in there, pending, again, how we've structured it and how we would want this to have, there'd be a quality component to it. So say met all the quality requirements. If it's 50-50, I would receive 50,000 of that 100,000. The payer would hold on to the other 50,000. This is a very high level, basic overview, but hopefully gives a reminder of how that shared savings could work. If there's risk, it can go in the other direction. So instead of, if it was $1 million and there's a 50-50, and there's also downside where the provider might owe money. If it was at $1.1 million, the provider actually, I might have to pay $50,000 back to the provider. To the payer. So again, that's where there's downside risk, or you actually might have to pay back money if you don't meet that target price. So upside, downside, just a brief example. Pay for performance can be based on quality or cost. So you might say, how many of your members have controlled diabetes based off of something like a hemoglobin A1C number. You can then pay based off where you perform, either based off of improvement or tiers based on how well you do compared to others. There's many ways of doing this, but then you can actually pay for those results. You can put multiple cost or quality measures together to then pay based off of that. So just walk through the strengths and weaknesses of these. So shared savings, shared risk. On the left, you'll see the strengths. So they encourage a bit of a more holistic view of member health. incentivizes investments in preventive care, reductions in avoidable ED visits and hospitalizations, which are big drivers of cost. Creates incentive to deliver high-value care by enabling providers to share in a portion of any shared savings, and then drives investment in a population health approach, including potentially investments in data infrastructure. There are limitations, as we've discussed before. Those include really must implement these with guardrails, including adequate risk adjustment to protect against lemon dropping. Some people also say, call that kind of strategic patient deselection in a different way, but essentially avoiding people to, so you don't end up potentially losing money on people who might be seen as not profitable. And then a quality program to against stinting. So those are really key components of shared risk shared savings, shared risk are the risk adjustment as well as the quality program. And you can't really implement this in small providers. It requires a large enough population to ensure measurements credible. And then it's also just not appropriate for all providers for various reasons. One, it requires some organizational capacity to manage, and also need capital to be able to do this. And you also have to remember there's significant regulatory limitations for FQHCs. Under pay for performance on the right, the strengths of that include creating a direct incentive to improve undefined cost and/or quality. It can be implemented with small providers, so our PCMH program would be a good example of that. Under limitations, its incentives must be sufficiently meaningful, so amounts should be large enough to compensate providers for the level of effort required to attain them. It doesn't incentivize broad-based accountability for member outcomes. It's specific to the quality measures that are utilized. I think we can go to the next slide. So just some examples of where these are currently used. And so we're just wanting to highlight a few of them, including the ones in our state, which we discussed last time. But just of note, you'll see on the left, these are incremental or performance-based payments. It's P for P, or the pay for performance. And then underneath that, shared savings, shared risk. You'll see in Connecticut, where we are, again, is PCMH and PCMH Plus. PCMH is a pay for performance program. PCMH Plus has a shared savings with upside only quality gated program. Other states also include these very, very commonly. You'll see Massachusetts, our neighbor, has their primary care ACO program. They have a pay for reporting and a pay for performance component tied to ACO quality, also in health equity, that's upside only. They also have a total cost of care shared savings model with risk that's upside and downside for their ACOs in 3 different risk tracks. Colorado, the next one over, Colorado's APM2 also has a shared savings that's specifically for certain chronic conditions with the chronic condition episodes with 50% upside only shared savings. I'll note CMMI also has several different P for P programs, many of which you've already heard about. CPC Plus, Comprehensive Primary Care Plus, has a PMPM incentive tied to patient experience, quality, and utilization. PCF Primary Care First also has similarly a 50% upside, 10% downside incentive tied to hospital utilization and per capita cost. And then Making Care Primary MCP is the newest of the CMMI demonstrations, has a bonus tied based on quality, utilization, and cost. So I think we can move on just to, again, demonstrate these are widely used, including in our state currently. And so there's some program examples, and just to highlight that you can do this in multiple different ways, highlighting that there's often tiers or tracks. So you can do it based off capabilities or readiness. So Making Care Primary has 3 different tracks that's recognized varied experience in VBP, value-based payment. And I'll also note, again, the Mass Health Primary Care ACO also has 3 tiered-based payment structures based on practice accountability. And then there's 3 ACO risk tracks that have shared savings, shares lost, that varies based on the different tracks. You can also base it off size. So for example, PCMH allows smaller providers to join and participate. PCMH Plus has a 2,500 member attributed member threshold. You can also do it based off population acuity. So Primary Care First does this. They have 4 different practice risk groups, and they have different P for P measures based on that. And then FQHC status. So Rhode Island Accountable Entities has shared savings, shared risk with required downside. However, for FQHCs, they participate with upside only. So there's different ways of doing this based off practice characteristics, different things you can take into account. Just wanted to highlight that, and I think helpful for this conversation. Next slide. So this is kind of a starting place in terms of where we see, again, these are our care delivery priorities. These are the ones we discussed. Chronic condition, behavioral health, and targeted care management. That's the first one. The next one is accessibility of care. The next is HRSN screening, community supports. Next is data infrastructure and data sharing.
Good, how you doing? Good. Can I have a checking deposit?
Mute there for a second. And then team-based care, the last one. In our initial assessment, we said pay performance or shared savings could actually help drive potentially all of these. We didn't say which one would help more or less. We did make some notes and considerations at the bottom, which I'll just note for the chronic condition and behavioral health and targeted care management. Shared savings does encourage a focus on management that is broader than you might have with, for example, P4P measures that are specific for specific outcomes. Accessibility of care. Shared savings encourages access to reduce avoidable ED hospitalization. You can also have relevant P for performance measures that are tied to that as well. For HRSN screening and community supports, depending on the impact that, say, that overall spend is impacted by HRSN needs, you could imagine shared savings having a marked impact. You can also have specific pay for reporting measures based off things that you can measure in terms of HRSN screening, for example. Data infrastructure and data sharing, both of these may encourage the use of data to improve performance, or probably will. You need to be able to measure your own outcomes or get that data and understand it. And then for team-based care, shared savings probably encourages broader care delivery model change, but pay performance, depending on its target, it can also encourage that. So we're looking for feedback. This is kind of a starting place, and this is where we'll be asking all of you for input on, do these various models work? And Ellen, feel free to jump in. I think we'll get to discussion just in a moment, but if you have any comments on this, feel free to start now.
Oh, so I could start now? Okay. On slide, I guess it's 12, I think I would have put that slide together differently. I think it's important to say that where you have strengths of shared savings creates an incentive to deliver high value care. That's not necessarily true. A lot of high value care doesn't give you a return on investment really right away. It may be, Medicare might benefit. It improves the quality of things. So it's only high value care that they get a very quick return on investment is incentivized. I think it could drive investment in population health approach, including investments in data infrastructure and all those great things, or it could just be profit taking. There's an awful lot that can harm people's health, but never get them to go into the hospital or cost more money. We found that under capitation. So that's, I have to take issue with that. I believe that it's a massive understatement that it implies that shared savings, when you say it must be implemented, the guardrails around lemon dropping and stinting, you need to understand that those guardrails are never going to be perfect. They're never going to be even close to perfect. So when you implement shared savings, you need to do it with an understanding that there is a potential to increase harm for people. And just understand that we're not going to be able to find that always. It creates, under the pay for performance, you said it doesn't incentivize broad-based accountability. That's kind of one of the positives for me. We don't mess with everything. We look at exactly what the problems we're seeing, whether it's, maternal, poor outcomes, things like that. And we can target money more carefully and accountability without necessarily, we can just deal with the bathwater and not throw out the baby. Also, I'm very concerned that the way you described shared savings would end up with the problem we had with CCMC, where they improved quality, but they didn't get any savings. They weren't allowed, they didn't hit the gate to get savings. And so they wouldn't have been rewarded for that. So you're only rewarding the numerator in value, or I'm sorry, the denominator. You're not incentivizing quality. You're only incentivizing it. It's a gate, but a gate with a lot of holes in it that, but you're incentivizing savings. Where else? Yeah, anyway, I guess I have another question about that, but I've probably talked enough. I'll stop now.
Thanks, Ellen. Maybe we'll ask Joe if you want to say anything, and Mark, and then we can ask some thoughts on the DSS.
Thanks, Ray. Quick follow-up. Ellen raises a good point about the issues around quality versus cost performance. What I would raise is that there are a number of programs that have a hybrid model, Ellen, where there are kind of two pathways where groups are rewarded for their quality performance, and they're also rewarded for their cost savings performance. So it allows them to focus on both of those potential areas and have potential opportunity for each of them. And so to make sure, I think what you're getting at is that the quality is always being focused on because there's an incentive there. And there's just a number of examples across both federal and commercial programs that have models that can be put in place. They're actually quite nice and quite complementary with each other. And that are not inconsistent with what groups are used to managing.
Thanks, Joe. Mark?
Thanks, Dr. Richards. So I look back and thinking about this, look back at some of the themes that came up in the listening session in July, which were summarized in August. And some of those themes that the work group members, the committee members really emphasized were encouraging an approach that rewards upstream prevention, supporting existing community-based collaboratives. So the community organizations, I think this was Stephanie Clark's point back in July, that there's infrastructure and overall capacity and community assets that could be, that play an important role in driving Medicaid impact. And also the idea of a whole person financing and accountability model, and that the financing and accountability should enable the participation of a broad range of actors, not just primary care, actors in the community and healthcare system who are critical in achieving the Medicaid impacts that you've laid out in terms of better biosocial health. So, so recognizing we understand the stipulation of DSS that we're really focused at the moment on primary care, but when you adopt the primary care model, it should be with a mind to a broader systemic solution that could be put into place that would complement primary care. I have a couple of thoughts. One is the traditional shared savings program model that was referenced in the slides, whether it's Massachusetts or the Medicare ACO model, all of them disincentivize prevention. And they do that, as I think Ellen noted, that they tend to focus on the near-term opportunities to simply change patterns of hospital use, for example. And they don't do anything to address keeping people healthy or keeping people from getting sicker. So to give you an example, the benchmark that is the basis for determining cost savings, the cost benchmark, is based on how sick your population is. So you have a higher cost benchmark if you have a sicker population. So if you have a program focused on prediabetes to try to keep people from being diabetic, you actually do better from a cost benchmark perspective if you have more diabetics each year. So fundamentally, shared savings program model, as it's been widely implemented in commercial and Medicare and Medicaid programs nationwide, has that as a fundamental flaw. And I would encourage us not to limit ourselves to a model that would perpetuate that. So I I think one of the other points that was made, and I thought that there was, if not unanimous agreement or consensus agreement, an impression that primary care is only one piece of the puzzle that's needed to address Medicaid impact in a big way. So most of the programs that are out there, Joe, that you reference, do have pretty modest impacts on quality. I think, as I noted before, CMMI has tested 50-some programs. Only 2 of the 6 that generated savings actually had material improvements in quality. And I think we do ourselves a disservice by not paying attention to what 15 years of model testing has taught us. So we've been kicking around ideas amongst hospital members that have in mind those themes that were discussed in the July session around SDOH and HRSN. And in our view, one could come up with something that is that has a cost benchmark, but that is not downward adjustments for improvements in the health of the population, and that has nor utilization, so that longer and consequently is not rebased every year or 2 or 3, so that the savings that accrue from prevention goals that often can't be met for 3, 5, 7, or even 10 years would accrue to the benefit of the actors that drive that. The other concept to sort of riff on the suggestion of a hybrid model is one could have a cost accountability model in which the responsibility or accountability for driving cost and quality and preventive health goals is shared among a number of entities, including community partners, not simply primary care. So where primary care receives a share of the reward for driving improved public health and healthcare outcomes, but only a portion of it, and that the balance of that savings could go to create a market for health reinvestments by hospitals and their community partners, behavioral health partners, and that sort of thing. So I would encourage us to think about an innovative approach that could be built out toward, where primary care, if you're launching January 1 of 2025, starts with a pay-for-performance model focused on diabetes, hypertension, asthma, and maybe behavioral health admissions. But that really then sets the stage for embedding primary care within a substantially more upstream-oriented model that supports the kind of collaborative work that really needs to happen in a sort of systems way, and doesn't happen today, and certainly isn't financed today. Thank you.
Thanks, Mark. Joe?
Thanks, Brad. Just a slightly different view on a couple of the points Mark had made, particularly around prevention and quality improvement in value-based programs. And I think his point about kind of the long-term, large-scale data is a valid one. But I think that most of the programmatic structure that is out there has a fairly significant focus on short-term quality improvement, and is a really integral part of all those programs. And this is just kind of feedback from someone who runs a number of these programs. We spend a significant amount of time building out quality programs for our patient populations. Now, those programs are driven by the structure of the program. And so I think if that's something that this group and DSS has flexibility upon, and the structure of the program can dictate the quality work that the providers are working upon. The other thing I'll mention is that what has become a fundamental piece of all these programs, which I think is a positive effect from them, is that the amount of focus on ensuring that all patients have contact on a regular basis with their primary care provider is just a fundamental best practice among all high-performing groups across these programs. And so I think what we're indirectly accomplishing there is regular access with primary care providers, which really for most patients is the point where quality and prevention starts and begins over time. And so we go through very, very significant efforts to make sure that happens on patients on a regular basis. And that is just a common practice among these groups. So I think in those two areas, I think programs like this do actually impact both access to primary care and then the initiation and maintenance of long-term quality programs and outcomes. And I think that we ultimately have the ability to drive what we want to prioritize by what we put in place as the incentives and the programs. And they could be different for different populations and for different programs. Thank you.
Thanks, Joe. Ellen?
I'm thrilled to be hearing so much about prevention and taking a longer term view. I think that we all agree on that. One sort of issue that I think we need to, I need to at least put a pin in, not a spade, a pin, that if it's a collaboration, then the savings have to be connected in some way. And I think it's important that it doesn't turn into the savings are directed then by the medical model, by the medical system, and that patients and community needs need to be included in that. I think there needs to be a process that when the savings are invested back in, patients have choice, and it goes back to the community services that improved the outcomes, and that they have some control and autonomy around where those savings go.
Thanks, Ellen. CJ?
Yeah, I just want to chime in and support what was just said and just emphasize the fact that, you know, not only is it expensive to be poor in Connecticut, but we all succumb to paying taxes, which fund these programs. So in saying that, I think it is perfectly expected for our input to be there. So I cannot stress enough the importance of all that was just said. Thank you.
Thanks, CJ. Polly?
Hi, I just wanted to, really, I do reinforce the concept that, connections with primary care, and that's really, the focus on creating that relationship and, then being able to connect individuals to other programs and services like, chronic condition management or prevention programs. I did just want to circle back on the, you highlighted the risk adjustment being a key piece in a total cost of care model. Most of those models have been developed for Medicare populations, and that's where, we have a lot of experience there. I think the challenges in total cost of care models in the Medicaid population that might have other SDOH barriers and things like that. I think we would just need to be really thoughtful about how we consider risk adjustment in this population, especially if, some of the things that we understand as being key drivers are data that might not be well developed today to inform that risk adjustment model.
Thanks, Polly. CJ, your hand's still up. Did you want to add something else?
Oh, no, sorry.
No problem. Just a few, I think, thoughts on this. I think, Mark, you'd said, we acknowledge primary care is definitely not the only solution to improving health and well-being that of the goals that have been set up for this, and just wanting to make sure, acknowledging that that's definitely the case. And I think there's definitely opportunities to blend some of the components here in terms of quality measures on more prevention to make sure that is focused on, and setting up, prevention quality guardrails around shared savings to make sure that there is a long-term, some of the things like cancer screening that we may see long-term savings on are focused on by providers. So I think there are ways of potentially blending this, just acknowledging, I think, Mark, the model you suggested is would be a very novel approach, which may be complicated and challenging to implement, especially for smaller providers. Though obviously we want to improve the health and well-being of our communities to decrease the rates of folks that are going from having pre-diabetes to diabetes. I think that's very, very, something that I think we likely all are very interested in doing. Some of it, I think, comes down to who's accountable for that. Is it primary care providers? How much accountability? Though I think it is definitely a goal that we should be striving for and thinking about broadly. How do we improve the health and well-being of our communities? Guy, do you want to? I think you may have some other thoughts. I might throw it to you just if you want to weigh in and add a few more thoughts.
Sure, absolutely. And by the way, this is a great discussion. This is, I hope all of our groups are this helpful. And if you see me looking away, I'm just taking a bunch of notes. I just want to make a couple quick reactions, and this is not going to be comprehensive to everything that everyone just said, but know that I, Brad, and others are listening. Ellen, I wanted to start. I'm going to actually start and end with you. And just to start, I agree with much of what you said. I want to posit that any payment model, if done poorly, has a lot of risks, including gaming and limit dropping. So just an example, I think at MAPOC last month, we talked about some of the challenges that our members with disabilities have with the current fee-for-service payment model, and how the current structure doesn't give providers strong incentives to serve patients who may take more time just based on the way the fee-for-service is done. And on the gaming side, there's lots of evidence to suggest, for example, when Medicare pays doctors more for MRIs, whoops, okay, there are a lot more MRI screenings. So I do take really seriously that gaming, limit dropping, and all of its cousins exist in any payment model, including risk, but also including fee for service, including the status quo. And I just, as a health economist who's always thinking about the unintended consequences of things, I just want to say that's forefront in my mind, both in any change and in the status quo. On the helpful, Polly, totally agree with what you were saying on risk adjustment, and that links a little bit to the discussion that Mark and others were having on longer term incentives. I just want to say explicitly, I very much agree, right? The HCC model that was originally developed for paying Medicare Advantage plans, a capitation payment, probably is not the right model for a Medicaid population for all the reasons that you described, including social determinants of health. And that is in part why, with our maternity bundle, for example, we thought carefully about social risk adjustment, recognizing that clinical factors like diabetes, but also social factors influence the expected cost of a pregnancy. And I think that would be very much true almost whatever payment model we picked. Obviously, the particulars would differ, but I just want to say I hear you and I very much agree. On the longer term incentives that Mark and Ellen and others brought up, I really like where you're going. I have real concerns about how this model, how a longer, and just to say it explicitly, like, I want to push back a little bit. Like, I do think some of the successful programs, at least in Medicare, I think have prevented, do improve health and have prevented illness. So for example, the hospital readmissions penalty program, I think, has quite good evidence. Yes, there's gaming. Yes, hospitals end up gaming that a little bit, but I think there's quite good evidence that it reduced readmissions and saved lives. But I hear what you're saying, where there's a bit of a policy ratchet, where if we're resetting the benchmark every single year, that can dull incentives for longer term prevention. Where I'm struggling, though, is thinking about how that could work with a smaller, medium-sized primary care practice that may not have, just the practicality of, if I have 200 patients, 2,000 patients even, putting me at risk for effectively multiple years of outcomes is very challenging. And I think a lot of our primary care practices would have a lot of difficulty, even financially, managing something so radical. So I guess I have a bunch of practical concerns, but I'm intrigued by longer term incentives, but I worry a lot about the practicality of it. I just want to end with a quick question for Ellen. You don't need to answer this now, but you mentioned, and I think CJ plus one, the autonomy for where the money goes. That sounds important, and I'm not officially tracking. I'm not 100% tracking, so it might be helpful for us to connect either later today or offline on what you meant there. Okay, that was a lot. I just wanted to say I'm carefully tracking, and this is a great discussion. Thank you.
Thanks, Guy. And I'll just maybe emphasize that I would say our fee for service, I think, Ellen, you had specifically said that shared savings obviously has risks, which I 100% agree that there is risk. I think fee for service also has risks that we do see, where people are getting a lot of additional testing at times that may be necessary, including people that are going to the emergency room. And again, I think there's risks on all ends. None of these models are perfect, and they all have risks and benefits to them. So I think it's just important to realize, like, there are existing risks to our existing models. There's good things about them too. And so it really, I think, depends on where we're headed and what we want to try to achieve to what we end up building. Mark wanted to pass it over to you.
Thanks, Dr. Richardson. Guy, I appreciate your comments and concerns about small practices. And sort of one thing I wanted to reference is sort of having in mind with thinking about other approaches that would be syntonic with what you're trying to do with primary care, is having in mind the Medicaid Transparency Advisory Board's recommendations about population health outcomes. And they're looking at things like reducing the prevalent incidence and prevalence of overweight and obesity, of diabetes and hypertension. And when you look at something like diabetes, the difference in morbidity and mortality between Black Americans and white Americans is largely a function of not only how good the care is, but also how likely you are to get it. And so, but you also have things, relatively radical ideas for a Medicaid program, like life expectancy at birth and third grade reading level and the racial wealth gap and stuff like that, all of which is either a reflection of or a driver of the health inequities that we see. So the problem from a primary care perspective, Dr. Richards, I don't think you can't put diabetes prevalence, incidence and prevalence in a standard ACO attribution model because it's actually more of an incentive for lemon dropping. If you have fewer diabetics year over year, it could be because your patient population has turned over and you've been and you look for patients who don't have the characteristics that are the focus of prevention. So while I think it's an important Medicaid program goal, I don't think it practically fits into an ACO type shared savings program model. I think it's actually, I guess I'd like to just offer a sort of hypothetical that would demonstrate how a small practice, a practice of say 3 primary care physicians with a panel of say 1,500 or 1,000 Medicaid beneficiaries could succeed under this kind of model. And that would be, let's say you created a regional cost benchmark and the accountability for driving improvement would be shared collectively among all the primary care providers, the FQHCs, the larger medical groups, and also the small individual practice, the ones and twosies. Everybody is measured as to whether, in working together with community partners and behavioral health partners and hospitals, they're able to drive an improvement in overall cost growth for the region. In that arrangement, if $1 million is saved in a given year, a portion of it could be going to primary care providers, no matter how small, because based on traditional quality rewards measures of the sort that we've talked about, preventable ED use, readmission rates, diabetes A1C control, hypertension control, well visits. And so you could get a share of the $1 million in regional cost savings based on how many people you have in your practice and how well you were able to achieve the kind of quality outcomes that are aligned with what primary care can reasonably do. So that's just one example of an approach where anybody can play and everybody is incentivized not to compete, but to work together to solve certain common place-based problems that often impact both the likelihood of getting a health problem, but also the effectiveness in managing a health problem once it's emerged. Thanks.
Thanks, Mark. Ellen?
I need to think about it more, but I like that. I like that a lot, Mark. It gives, you could really, my issue with, say, picking like, community measures to risk adjust means that it's very hard for one practice to make a difference in a whole neighborhood. But if you did it collectively, they could put everything together and really make a difference by, if they see in their community there's a problem with, food, they can create a pantry or support a pantry. I think that's awesome. And maybe open up their facility to, for cooking lessons or something. Just could get really creative but in a regional way. Also, as if you do it collectively, any individual small practice or any individual provider has less incentive to stint, or I actually prefer cherry picking. Can we call it that instead of lemon dropping? Can we not refer to less lucrative patients as lemons? Anyway, that's an aside, but I think they have less incentive to do those things because they're not going to directly benefit. They'd get, pennies on the dollar from that. I like it. Oh, and I had a question. Why did I think Mark brought up FQHCs. Rhode Island excluded them from theirs. Why is that? Are we not allowed to? Because that's a big problem. They care for an awful lot of people in Medicaid, and they have traditionally had some serious quality issues.
Ellen, I can
I
take
can-
the FQHC.
Okay.
And I don't know or I guess if someone else knows particular Rhode Island to chime in, I was just going to say, very much agree that FQHCs play a critical role in the Medicaid program. That role is reflected just process-wise. We have an FQHC subcommittee of this process reflecting their critical role. As you know, FQHCs under federal law are paid with the PPS rate, and FQHCs at their option can participate or not in alternative payment models that do not use the PPS rate. So I know many Medicaid programs struggle, maybe isn't the right word, but many Medicaid programs, when they're thinking about how to pay or have a different system for primary care, are challenged with the PPS structure and thinking about how to include FQHCs in it while being fully compliant with federal law. And in particular, some of my fellow Medicaid directors struggle with, okay, if you roll out a program and you make it optional, some FQHCs participate, some don't. That creates issues of potentially of selection. But anyway, it's the federal law. Olivia, I don't know if you were about to jump in with the Rhode Island experience in particular. Yeah, great. That'd be helpful if you would chime in because you know more about Rhode Island than I do.
Yeah, I just threw it in the chat, but just for the sake of clarification, they participate in the program. They don't participate in downside risk. So their only limitation, right, is around in terms of the total cost of care model. They have an upside only model for some of the reasons you just described.
So that's similar to what we do with PCMH Plus.
Exactly.
Okay.
The difference being the sort of tiering that exists because the non-FQHC providers, right, in Rhode Island are required to take some downside risk in the total cost of care model. So you could think about it sort of as slightly different to PCMH Plus, which sort of has one track, right, where everybody is upside only, where this is sort of two tracks, where you have a sort of non-FQHC track and then an FQHC track, where there's that distinction around the
That severely limits the ability to change some of the things we've been talking about. I think it deserves some thought around that, how we build something that includes the FQHCs as well, because we're not going to get very far if they, 20-25% of patients are attributed to FQHCs. That's a big chunk to leave out of all the things that we're talking about.
Very, very much agree, Ellen, that they're a key part of this.
Ben, and then CJ.
Thanks. So, one thing that I've been thinking about as we think about the payment model is something that you guys have actually been reinforcing for us as we move through this process, which is that primary care is an incredibly important piece of solving this, the challenges that we have, but it's just one piece. And especially for a Medicaid population, as opposed to, the Medicare population or commercial population, the social issues and some of the population issues are major drivers of both quality and cost. And I think you guys have rightly pointed out to us that while primary care has a very important role to play in that, it can't do everything. And so I think that the model that Mark has been talking about is very exciting because it recognizes that it's a community-wide approach with many stakeholders if we're going to move the dial here. But my concern would be that, and I think that we can do something that fits primary care within that broader context, part of the work that we're doing here, but expecting that the primary care model is going to be the solution to all of those problems, and creating a payment model that reflects that would be, I don't think that would be fair to primary care providers. So I think, doing more of a pay for performance model that is geared more towards clinical outcomes, or utilization changes that we'd like to see, that probably feels like a better way to go. And I think the other thing we spent a lot of time talking about is access. And if we're going to ensure that we have the level of access that we need to make it possible for more providers, more physicians to accept Medicaid. And doing something that is based on the total cost of care requires a level of risk spreading that would make it very, very challenging for, if not impossible, for small providers or small groups to participate. Just another thing I think that's important for us to keep in mind.
Thanks, Ben. CJ, Polly, and Joe.
Thank you. I just want to draw attention to what our friend Angela is putting in the chat, because it is true. In our neighborhoods, we lack access, period. And that comes down to things like food, right? We get thrown these pantries, which are nice, don't get me wrong, we love it. Thank you very much. But we're not a pity party here. We need real resources. This is where most of your people are coming from, but then they're not even getting the care and the treatment they deserve when they walk out their door. We have more corner stores per corner that are exploiting our communities, feeding them bad food, creating the diaspora. And we also have a problem where our providers are not being really supported. And I like and appreciate what was said about those who are smaller businesses, which tend to be Black and brown. Representation matters. When thinking about this whole thing, let's not forget that. More people are more likely to engage in their own healthcare when they see someone who looks like them, because it's a safe space and it's supposed to be that. So consider that word while you're collecting all your data, which, I'm glad that you're collecting the data, but let's not lose focus of why we are doing what we're doing. Rosa Parks forced a decision there, right? Nobody thought it was possible. So sometimes things have to start off brand new and challenge what was happening before. Thank you.
Thanks, CJ, and thanks for highlighting Angela's comments. I just wanted to remind, just say broadly, we are planning on talking about health-related social needs again next in depth in our next session. I just want to agree that food is a huge, food insecurity is a major driver of poor health outcomes, and also is something that I think, I suspect we all agree, is a major concern to actually improve the health and well-being of our of Husky members in the state. So, Polly?
Thank you. I just wanted to maybe kind of piggyback a little bit on what Ben said, and reiterate the connection with primary care in our prior discussions around, I think it was 60% of the adults are attributed to primary care. And so how do we think about closing that gap, getting more individuals, who may be using our emergency departments or not being connected to care, and really ensuring that we can, get those relationship-based established, or break down any barriers around understanding of the value of primary care and, some of that health literacy component. And how do we use our, not only, places like the emergency department, but potentially those community partners to help create those connections. And I think, again, there's, some nice opportunities for synergies with, what Mark was describing, but also, with the ability to put infrastructure and supports for the primary care providers to, have these enhanced care team models and to develop those programs for patients that are connected to primary care.
Thanks, Polly. Joe?
just wanted to comment on a thread that's come up a couple of times around the access of primary care groups to these programs, and particularly smaller groups. And I did want to say that it has become fairly common and standard for a large number of those groups to access these programs through a partnership with a larger network. And when you look across the breadth of the state, between employed physicians and affiliated physicians, it represents a significantly large percentage of the primary care base. And so even for small practices, they've kind of chosen to access these programs through these partnerships, which allows them to pool resources among different groups. Now, it certainly doesn't represent 100% of that practice distribution, but it's a pretty significant component. And for the most part, any groups that are not already part of that likely would have the opportunity to participate in some model. So I think we have the flexibility to think about that from both perspectives. We obviously want to make sure that all practices have the opportunity to participate, even small groups, but there already is a confluence of these groups and partnering in large groups together. And many of those other small groups who are not already participating would likely have the opportunity of a number of partners across the kind of spectrum of how different advanced networks are structured.
Thanks, Joe. Angela?
Yes, I would ask that whoever's taking notes, if you could please pull my comments into the notes from your into your platform. But also, I would like to lift up the fact that, as addressed in the chat, food insecurity is literally food apartheid in the state of Connecticut, in the land of the haves and the have-nots, one of the richest states in the in the nation, and we have some of the poorest pockets in the country, in our state. That's why we have the Hartford Promise Zone, the North Hartford Promise Zone, because we were designated amongst municipalities across the nation for having such high need. And if we don't figure out a way in the shadow of the state capitol to address the drivers of some of these chronic conditions, we're spinning our wheels and going nowhere. DSS has to find a way to allocate some of its resources, give incentives to retailers, whoever might be able to address this issue. And it's been an issue for years. Literally, a supermarket that was burned when Martin Luther King died more than 50 years ago hadn't been open and just got torn down for what, a library to go in its place. But we still have no food access in our neighborhoods, which is ridiculous. And everyone says, you know, oh, retailers don't want to come. It's profit margin. It's profits over people. When we had the pandemic and DSS rolled out their, options for ordering online, finally getting EBT to be able to get food delivered to homes. One of the main sites was in West Hartford on the Hartford border. The supermarket closed. So it's like if you do a heat map of diabetes and then food stores, you'll see that we have a problem and we have to address it. And pantries are not the solutions if they're not going to provide fresh, quality food to address the needs. If you add more high salt, high sugar, processed preservatives on top of diabetes and high blood pressure, you get more of the same. So if we don't put our resources where we know they're needed, shame on us.
Thanks, Angela. And CJ, I see your hand. Just one quick reaction that I'm going to ask for you back, for you and others. So I agree. This is an important issue. I think there is good research on food as medicine, linking access to high quality healthy foods to better health outcomes, including in diabetes. The thing I want to get your thoughts on, maybe especially in the March meeting where we're gonna return to health related social needs, is the role that DSS and Medicaid, and in particular primary care, should be playing, and where you see the biggest opportunity. And that's something Brad and I and others have really gone back and forth a bit on, and would really welcome your and others' thoughts and experience. CJ, I see your hands up.
Thank you. I just want to back up Queen really quick in saying that I hope that you do transpose her comments and make it publicly visible. Part 1, part 2, while some of us just observe Black History Month, some of us live it every day. Number 3, the fact is some of us have gotten real comfortable disrespecting Black and brown women in leadership. It's kind of trending. So that being all said, we're talking about primary care. We're talking about different things that are actually related. And what's happening is, I want to note what was previously said about the food pantries. There is no quality check-in happening. All right. Some of these pantries are getting, post-dated food, it's the items that are not actually usable. And while we may say, well, what does this have to do with primary care? Well, if I can't afford my food and I go to, get something and I can't afford that, why would I go to the doctor? Why would I want to fill out in my information? Why would I want to do anything if everywhere I show up, everybody who's making decisions, providing care, they don't look like me, right? So I just want to say that, and thank you, Angela, for your comments.
Thank you, CJ. And I think we will look to revisit this. I think the holding up piece kind of asked to Angela and to the broader group to revisit this conversation in our next meeting. I do want to make sure there's a few sub questions which have already been touched on, including the needs of various practices, and also mention to make sure that are there strengths and limitations that we have to consider in terms of these incremental payments for the different practice sizes, which I think has already come up. I just want to make sure if there's any other comments that want to be raised, we capture those and we hear those. And also just note the last questions also there, and just scroll down to that, is the mitigation strategies, which I think have come up a bit in terms of addressing unintended consequences. And I think Ellen spoke to this. We mentioned the need to make sure there's guardrails in place, the importance of that. And I just want to see if there are any more comments that people would like to make sure are captured as we discuss this. I think, Angela, did you want to chime in at all, or just?
Yes, I just wanted, I dropped it in the chat. We must put our creative thinking hats on and think outside the box, because the status quo is literally killing us. It may not be where you live, but where I live, it's killing us.
Thanks, Angela. Appreciate it. And I think we very much appreciate that, raising up the concern around food insecurity, food as health, food as medicine. Definitely things that I think have come up with this group, and also things that the broader DSS team has been thinking about, as well as housing, and other health-related social needs supports. Seeing no other questions, I think maybe we'll move on to the next slide, where we just note, we wanted to make a space to see if there's any other, that's okay, yeah, I was just to say, we'll see if there's any other feedback, topics or considerations that we haven't discussed on especially payment or anything else people wanted to raise. I think the points that Angela, CJ, and others have raised on the importance of thinking outside the box and health-related social needs. Again, we'll bring that back. Ellen, please go ahead.
Yeah, there was something, one of your questions was about whether it makes sense to have tiers, and I think it does, because one size doesn't fit all. And it might, I think they should be tiers for quality as well as savings. And I mean, we can't lose any providers in Medicaid. So I don't want a cliff where there are some winners and everyone else loses. It would be good to find a way to incentivize everybody, and the incentives you get are proportional to the, how well you do. We want to have everybody have a reason to improve.
Thanks, Ellen. Ben?
Thanks. I just wanted to make the point that you've laid out a few different ways that we might go about doing this, and I know that it adds to the complexity, but it may be that the right approach is that there might be different tracks that providers or groups could be on, and giving those groups the opportunity to determine what the right track is for them, based on their size, whether they're a part of a larger network, whether they want to be a part of a larger network, how ready they are to take on some non-traditional healthcare functions. That seems like it would be beneficial. Even within this group, you have different folks who have different perspectives. And I think the goal is to make sure that we're moving in a direction for the entire state, for everyone in the state, that we're providing the best care for them. So we wouldn't want there to be something that some folks feel like they can't participate in at all, they're not ready to, and then an entire population gets missed.
Thanks, Ben. Yeah, I think definitely the goal is to have a broad-based program, and I think these comments are very helpful to hear. So very much, I think, aligned with that overarching goal, and helpful to hear that specific feedback.
Fred, the other thing I was thinking is there may be an opportunity to think about what gets paid for in a fee-for-service way and what might get bundled into a PMPM. And I don't think we need to feel like there's only one approach. So even if you think about behavioral health, behavioral health payment for an integrated practice, some of that could flow through a fee-for-service model, but then other services could be covered through a PMPM.
Thanks, Ben. Polly, do you want anything else? I just agreed with Ben.
No, I think that it's just a really important point. I know we have highlighted the degree to which we can offer choice and flexibility, while kind of aligned on what the core goals and outcomes are that we're striving for. Again, recognizing that there are practices that are different points of their kind of development or advancement in these population models, I think would be well received.
Thanks, Polly. Ellen, and then Mark.
Yes, I was looking back at the 4 things, the strategies. We spent a lot of time on the payment models, but you also talked about investing in data infrastructure and data sharing and other centralized investments, and also providing technical assistance to providers. I think that's really important that they get data that's actionable, that's timely, that they can actually use. And I think there's a lot of tools. I mean, we're having a webinar with Greg Lowe from Mass General, and they've done some amazing things around provider education and performance reporting to help improve quality and also efficiency in prescribing, and that could be available to everybody, big groups and small groups. I think that kind of information and giving tools and technical assistance can be really effective.
Thanks, Ellen. Mark?
Thanks. My colleagues reminded me about some of the points that we covered in our recent meeting with members about behavioral health integration. And thank you again, as I noted in the chat, for incorporating the behavioral health in the way that you did explicitly in the model. And it was also, so we thought about, well, if you really went strong on trying to enable behavioral health integration, and and you also posed this question last time of what should we put into a fee-for-service primary care solution versus a PMPM add-on. You also raised the question, of course, of a full primary care cap, but and our members are mostly feeling this is the time, and I think this was reflecting less discussion, to keep the foundational payment for primary care intact and to talk about new capabilities in a PMPM. But that raises a question about behavioral health. And with behavioral health, one of the biggest problems we encountered in our discussions with members is that it's extraordinarily challenging to recruit and retain behavioral health providers, clinicians, psychiatric consultation in primary care settings. Enormously challenging. And so, on the one hand, there was consensus among the members that the CPT manual has evolved in such a way that there is actually a broad array of behavioral health relevant codes for everything from a health behavior assessment to strategies for helping patients manage stress or co-occurring behavioral health issues, or as a primary sort of therapy counseling type encounter. Those codes are out there. So are codes to support advanced integrated care models like collaborative care management. Those codes exist, and I think DSS adopted them in the past 2 years or so. So it's in our view, because Medicare and commercial payers, Medicare especially, and to some extent commercial payers, have aligned around the expanded use of these codes to enable behavioral health integration. Our feeling is to not change that. And I think, Joe, your comments last time were, don't develop a different model for Medicaid if there's already a method for reimbursing through commercial, and correct me if I'm wrong, because you know the commercial market better, or Medicare for something like, so for some aspect of what we want to do. So our strong recommendation is to ensure the coverage of behavioral health, the full array of codes that are available in the CPT guide for behavioral health related interventions in primary care, but to pay close attention to the issue of payment adequacy. A universal concern is that the reimbursement that one gets for behavioral health providers co-located in a practice or integrated in any way is that the reimbursement isn't sufficient to retain those staff. And so we had somebody talk about a psychiatric APRN who is actually integral to the functioning of the primary care team. A huge assist for direct patient care, but also consultation to the primary care team. And they simply couldn't retain that person because there wasn't enough funding to support it. And the behavioral health workforce is as much under pressure, limitations as any other aspect of the healthcare workforce. Can't emphasize enough the importance of figuring out a pricing model for the behavioral health component sufficient to support the recruitment and retention of behavioral health providers. One of the other reasons for doing fee-for-service is because the access to a behavioral health workforce is a constraint, or the size of the practice and physical plant may limit what you can do in terms of having folks on site, that the fee-for-service model would create the flexibility to grow your practice and to integrate behavioral health as you're able to, and then you can immediately start billing for the fee-for-service components. So it seemed to us the most flexible for supporting both the small practice that might have certain physical plant constraints, as well as the larger clinically integrated network, which, by the way, are comprised oftentimes of these different sort of practice locations with constraints. So really doubling down on the fee-for-service component of behavioral health integration. We looked at the two models, team-based models that are most commonly adopted at the most advanced end of behavioral health integration, what's called primary care behavioral health, not a very innovative name, and then collaborative care management. Both have been used to good effect by our members. In some cases in their networks, they have both models in place in different ways and different practices. So we endorse the giving practices the flexibility to adopt the team-based care model that is best aligned with the way they want to do practice and the way that their patients feel is most responsive. And then there are some aspects of behavioral health that are not fee-for-service reimbursable, like getting somebody connected to a recovery coach or to an Alcoholics Anonymous or Narcotics Anonymous, or getting somebody plugged in to a faith-based support, or getting somebody to a behavioral health specialist, substance use specialist, or what have you, not inside their network. And that kind of care management or care coordination, we feel ought to be part of how you think about pricing the PMPM add-on. I welcome Dr. Kroll, Polly. I think you were both part of that conversation. If there's anything that I left out. Thank you.
Now, I would just reiterate, absolutely hit it on the nose there, Mark, and, an absolutely critical investment, but also a workforce challenge. So thinking about all the ways that we can provide different payment models and appropriate reimbursement for that will be critical to developing this infrastructure.
Yeah, and I agree. It's especially an issue for pediatric practices around the state, and quite a big challenge, not only because there are no, I'll just talk about our network. There is not one pediatric practice in our network that is 100% Medicaid. So they're providing behavioral health. They're trying to provide behavioral health services for all of their patients, not just patients on Medicaid. And depending on the payer mix, there may be, you might consider Medicaid a good payer, but some of the private payers pay half of what Medicaid pays. And it's just not sustainable. If the expectation is integration, meaning having a behavioral health provider in every primary care practice, which we've already discussed, some don't have the volume, some don't have the space. We've got to try to find creative ways of not only sustaining these professionals in these settings, but also hiring these professionals into these settings and then training them how to function in a primary care setting. Because again, behavioral health, well, it may seem, well, we might expect that all behavioral health providers know how to function in a primary care practice. That's not part of their training. There's also a training component there.
Thanks, David. And thanks, Mark, Polly. CJ?
I just want to add to that we didn't even get started on how Black providers and Black staff, Black and brown providers and Black and brown staff are paid and treated, which all affects everything. Because how are we saying that we care about people, but then you're bullying your own staff, right? So there's a lot of training opportunities that should be happening to empower the services you're providing and to prevent backlash, and also open opportunities for other providers to really get paid and be part of this work. I just want to put that up for consideration.
Thanks, CJ. I think with that, we'll move on just to kind of recap what we heard, I think, in our last meeting, just to note key feedback that we heard some mixed, talking about that base payment model. We heard some advocate for fee-for-service, some said PMPM or population-based payment, and then others said a hybrid model, which again, I think we've heard today, thinking about that base payment. And that some design considerations is like building that flexibility and about broad-based consideration. Again, I think that's come up today, acknowledging some larger providers have more experience and are able to do risk arrangements others will not be able to, or smaller. And then the need to align with other payers, again, coming up today as well. Again, this is from last discussion. And that in an ideal where we limit model complexity and administrative burden to ensure participation and patient choice. Again, I think a theme that's come up again today. So our next meeting in March is going to be on the equity strategy review, which will also talk about health-related social needs. Our equity strategy has been brought in throughout as we're trying to think about how we loop it into this overarching model, acknowledging that, again, primary care can't do everything when it comes to health equity, and there's lots of things that are major drivers that have come up today, including food insecurity and access to food. And then we're planning an in-person meeting in April to kind of wrap up our phase 2 review and opportunities for further comment on that. So we're really finalizing plans and looking forward to it. That's really it for today's conversation. I think this has been extremely helpful, really useful comments and points that were brought up. And Angela, I see your hand, so I'd welcome hearing from you. And then I also will ask Guy if he wants to chime in with any final comments.
Yes, again, I want to direct your attention to the chat. There are some comments regarding the reinvestment of any cost savings to folks that are working on the ground. I think if it isn't already lifted into the notes, that should definitely be highlighted for our follow-up.
Yeah, and that's been brought in to the overarching notes from the meeting. So
yes, thank you.
Guy, anything you'd like to add?
Nope, other than thank you. Your time is valuable. I took a lot of notes, given us a lot to think about, and looking forward to our discussion next month.
Agreed. Thank you all. We'll talk soon. And Tiffany just noted that we're capturing all of the notes from the chat as well. So thank you, Tiffany, and talk to you all soon. Bye, everyone.